All right. Well, good morning to everyone who's joined us. I know we're going to have many joining in the next few minutes, but I want to get us started because we have a pretty packed couple of hours this morning. So thanks for joining Reforming Payment Systems to Drive High Quality Holistic Maternal Infant Care. This is the fourth of our MAP to Action work sessions. And so the MAP, of course, is the Maternity Action Plan. We're really glad to have you all here today. And we've got three really excellent co-facilitator speakers who'll be joining us as well. Just a couple of things as we get started. Number one, we are recording this presentation and we will be making it available. So if there are parts that you want to see again or take a look at, the recording will be made available to you. Additionally, like I said, we've got a packed couple of hours and we don't have any built-in breaks. So if you need to, please feel free to step away. A note about timekeeping, we've asked our three speakers to cover probably hours worth of materials in a range of 10 to 15 minutes. And so we have already warned them, but if you see me take down their slides and it feels like they're not quite finished, we'll be able to move into two breakout rooms that will, where our speakers will also be located, and they'll be able to follow up on any thoughts that they were sharing with you. And that will also be a time where you'll be able to ask questions or engage in dialogue a little bit deeper. We won't be having any time for questions or answers in the main room. Those two breakout rooms will happen about an hour into our day today, and we really look forward to continuing conversation in there. Additionally, we'll be sharing 2 out of our 3 slide decks. I know that's always a question that comes up in the chat box. We'll be sharing the slide decks from HealthySteps and NJ FamilyCare. Unfortunately, we're not able to share the Horizon slides, but again, I'd encourage you to go back to the recording if there's something that you wanted to note from those slides that you want to pick up on again. And then lastly, you have all received a partner engagement worksheet via your pre-meeting materials. We'd love for you to take the time after this meeting to open that up, fill it out. It just takes a matter of minutes, and send it back to Brianna. That will help us prep for our MAP to Action convening that's happening this Friday that we hope you all can join, and more to come about that at the end of this session. So all of that being said, I'd love to introduce our speakers this morning. I'll start with Dr. Simone Edwards. She's a devout healthcare leader, health equity champion, strategist, professor, mentor, and advocate. She's currently the Director of Special Projects in the Community Health Department at Horizon Blue Cross Blue Shield of New Jersey. She leads efforts in advancing health equity, particularly in maternal child health, and addressing social determinants of health amongst the Medicaid and commercial membership. She's a master's level public health professor and currently sits on the board of the Community Food Bank of New Jersey, the Empire State Medical Association, and the American Heart Association Go Red for Women executive leadership team. Dr. Edwards acquired her bachelor's degree in biology from Stony Brook University and continued on to New York Medical College, where she received both her master's and doctorate of public health degrees. She received a certificate in leadership development to advance equity in healthcare from the Harvard T.H. Chan School of Public Health. Additionally, during her academic career, she's had publications, awards, and active memberships in healthcare executive organizations. Among those involvements, she's played an active role in organizations that conduct medical missions in foreign countries where there is evidence of unsustainable healthcare for vulnerable populations. Dr. Edwards has dedicated her over 15-year career in healthcare field to advancing the health and well-being of the underserved population. She continues to feed her insatiable interest in community and population health by being an instrumental contributor to community-based initiatives, mentorship programs, and academia. Dr. Edwards, we're so glad to have you here this morning. Next, I'd like to introduce you to Pamela Tu. Pamela Tu is a licensed social worker and leads the HealthySteps National Office Policy and Sustainability work in New Jersey. She works with strategic partners across the state to secure sustainable funding streams to support the implementation and growth of the model. Ms. Winkler-Tu joined 0 to 3 in March 2020, coinciding with the launch of the first 4 New Jersey HealthySteps sites. Prior to joining the HealthySteps National Office, she was a senior program officer at the Center for Healthcare Strategies, where she led the organization's child welfare and Medicaid alignment work. Ms. Winkler-Tu was also the associate director of the Pennsylvania Council of Children, Youth, and Family Services, where she worked closely with child welfare, juvenile justice, and children's behavioral health and community-based organizations, advocating for strengthening the services and supports for children and families. Ms. Winkler, too, started her career in social work supporting victims of intimate partner violence and children with serious behavioral health needs. She earned a Master's of Social Service degree at Bryn Mawr College and a Bachelor of Science in TV, Radio, and Film in Syracuse University. Pam, we're so glad to have you here this morning. And then last but not least, I'd like to introduce Greg Woods. Gregory Woods is the Chief Innovation Officer overseeing the policy and innovation portfolios at the New Jersey Division of Medical Assistance and Health Services, the agency that's responsible for administering the state's Medicaid program. Prior to his time at the state, he has worked at the Federal Center for Medicare and Medicaid Innovation, the Federal Department of Health and Human Services, for a health policy consulting firm, and for a nonprofit focused on behavioral health issues. He has a master's in public affairs from Princeton School of Public and International Affairs and a bachelor's degree from Columbia University. Greg, thanks for joining us. I'm going to turn things over to Linda to set the context for this morning. Linda?
Thank you, Kate. As Kate mentioned, this is the fourth of our series on the Maternity Action Plan. And for those of you who are not aware, the Quality Institute released a Maternity Action Plan in July of 2022, and the plan is exactly that, a map, a directional path forward in 4 critical areas to address New Jersey's maternity health crisis and eliminate racial disparities. Next slide. So hopefully you're able to participate in our first 3 sessions. This is the final one, and it focuses on driving or reforming our payment system to drive high quality, holistic maternal-infant health. We are focusing today on 2 of the 3 recommendations. The first recommendation is to support and sustain existing maternal-infant health programs and to need and launch and leverage other additional payment reforms or pilots. And we're focusing on the third recommendation, which is to build upon and scale existing care models that focus on a continuum of integrated care across the full perinatal period. Next slide. The purpose of today's session is to really allow all of you to dig into the work that's happening, to understand it better, to ask the experts that are presenting today questions about it, and to really see how that work connects to the work you're doing or the work that you would like to be doing. We want to also make connections and hear from all of you as to what you think about this ongoing work, how it relates to your work, and any barriers that you're having. And so that will be the types of discussions that we're hoping to have in the breakout rooms. We're also going to be carrying this conversation, as well as the other 3 conversations that we had in the first 3 sessions, forward to our in-person session, which is this Friday, as Kate mentioned. And also wanted to share that worksheet that Kate referred to. We really appreciate those of you who have been filling those out. You can still fill them out on the first 3 sessions if you haven't yet, and we encourage you to do that and to also fill them out with respect to this session. We're collecting that information, and we're really using it to build a robust dialogue at our session on Friday. We're collecting information on what all of you have and what all of you need, and really connecting the dots to help all of your work in driving maternal infant health forward to make and to advance birth equity. So thank you for participating in all of them. And at this time, I have the distinct honor of turning things over to our first speaker, which will be Dr. Simone Edwards. And as I mentioned, Dr. Edwards will be focused on new models of care, particularly in the maternal infant health space. So Dr. Edwards, thank you.
All right, good morning. Thank you, Linda. I hope you can hear me. Okay, wonderful. I'm excited to be here. And to definitely represent Horizon, talking about reforming payment systems and bringing some of the models that we currently have at Horizon. So next slide, please. So before we get into all of that, I want to sort of level set folks to get an understanding of Horizon and our placement within New Jersey. So Horizon has over 3.8 million members in all of our segments, and I'll talk about our segments in a bit. We have over 60,000 local providers. It's important for us to leverage our local providers. And also within each of our market segments, we have the largest market share in New Jersey. Now, this information was taken in a snapshot period of time, and that can change at any time. But when the slides were developed, this is the information that was most current. So I mentioned our segments. If you aren't aware of the various segments and markets that Horizon has, we have the individual market, small group, mid-sized group, commercial and ASO accounts. We have the state health benefit program, Medicaid program, Medicare. We have the FEP program, the federal employee program, labor, gaming, and public sector. Next slide, please. So Horizon, the way we function is definitely everything is tailored around our members. The member is the central focus. So when creating our mission, our vision, and our values, the members are at the forefront. So our mission is to empower our members to achieve their best health. Our vision is utilizing and driving innovation to improve our members' quality outcomes, to create affordability, and to ensure that our members are having the best healthcare experience that they can possibly have. And we go about doing so with some core values. We strive for a culture of excellence. We have a member-focused approach, which I mentioned before, and we think innovatively. Next slide, please. So I wanted to also highlight Horizon's commitment to diversity, equity, and inclusion. We have our commitment broken down into 5 pillars. We will listen and learn from our community. We will reflect the diversity of our community. We will collaborate with leaders in our community and across New Jersey. We will promote equity, inclusion, awareness, and understanding to confront racism, hate, and discrimination. And you may realize that I missed the 3rd pillar. I'm coming back to that now. We will address healthcare disparities related to race and the social barriers our members face in accessing care. And we'll talk a little bit more about that later on. So in the next few slides, I'll be talking about, next slide, please. Thank you. I will be talking about the different levers that we have as a payer, and a payer in New Jersey, a state that is ranked number 47th in maternal health, and identifying the various levers that we can pull as a payer in addressing maternal child health. So I have selected a few of our programs. The first one here is a bundled payment program, which is called the Episodes of Care program. And when you think about the Episodes of Care program, I want you to think about a practice, a hospital system, or a doctor in particular who becomes the conductor or who orchestrates the full spectrum of care for pregnancy in this situation. We have multiple types of Episodes of Care programs. And for the purpose of this presentation, I'll focus on our pregnancy Episodes of Care. So the primary goal for our Episodes of Care program is to standardize and optimize care and the cost of care. We compare like patients and with like outcomes, and we study variations in the utilization and cost of each of those patients. When you think about the focus of the episodes model, the model itself, we identify pre-trigger services, a triggering event, and a post-trigger, the post-trigger service. For the pregnancy episode, we have the triggering event as the delivery the baby. And then we do a 252-day look back to see all of the activities surrounding that birthing person during that time. And then a 56-day look forward in the care that the person received after they have delivered. And from that, the payment is specified. So you may be wondering, has the program been successful? This pregnancy program actually has been up and running since 2014. The program has been successful because of these reasons. When the program was developed, it was developed hand in hand with the providers. We ensured that it was simple to implement in the practices. We ensured that there was respect as it pertains to the providers, because the providers are the clinical experts and we understand that. We also identified that, the patient should be the center. They should be at the front of the decision-making process along with the provider. And for the first few years of this model, retrospective model, there was no risk at the beginning of the program, which will then ensure and enable evolution of change in this model. So as we and to the right of the screen, as we talk about, the provider working hand in hand with the program model, we've identified the metrics that will be measured for this particular program, and that's to the right-hand side of the screen. We focus on readmissions, on planned hospital visits, tobacco screening and counseling, and we also pay close attention to C-section rates. And I can say, since the program has been established, the stakeholders, the providers that are part of the program, they have seen a decrease in C-section rates and preterm births. They have identified that costs have been lowered with the existence of shared savings at the end of the program. And most importantly, they have found that the patients seem to be more educated and they're more actively engaged in their care, which is a big plus. Next slide, please. So the other program that I wanted to share with you today, due to the interest of time, I can go on and on, are quality programs. And as you can see on this slide, our quality programs are geared towards different stakeholders. We have a quality program that is geared towards our providers, and the other that's geared towards our patients. So let's talk about the provider quality program. So the provider quality program at Horizon is called the Women's Health Results and Recognition Program. And this program is geared towards improving quality outcomes through practice transformation. The lines of business that are participating in this provider quality program are our commercial lines and our Medicaid lines. And we focus on measures such as ensuring prenatal and postpartum care visits, cervical cancer screening, breast cancer screening, and chlamydia screening. And the providers receive an incentive based on the outcomes of these measures. Moving on to our quality program that focuses on our patients. And this one is called Mommy's Health Choice Rewards Program. And this program lets our members earn rewards for taking care of their health. Again, going back to our mission, ensuring that our members are at the center of the focus of their healthcare. And now we're enabling them to be empowered to take charge of their healthcare. So the line of business that participates in this program right now is our Medicaid line. And we look at measures that are pretty similar to the other measures discussed before, ensuring that prenatal care visits are completed, empowering our members to have postpartum visits. And one of the important pieces here, which is oftentimes left out is to ensure that postpartum mental health screening is completed. Maternal mental health is a very important aspect of the overall maternal health area. And I'm glad to see that we have a program that addresses that and empowering our members to focus on this. So next slide, please. So before I end, and hopefully I don't get kicked off, I hope I'm within time, I want to focus on why it's important that we look beyond the Medicaid insured members when we're designing perinatal models. And I just pulled some quotes from different entities as it pertains to why this is important. And let's start with a quote from the CDC. Maternal health disparities are closer linked to race than any, sorry, I have something here, socioeconomic factor. And it goes on to saying that notably, the pregnancy-related mortality rate for Black women with a completed college degree, college education or higher is 1.6 times higher than the rate of white women with less than a high school diploma. Most recently, I want to say it was last month, or earlier this month, the New York Times released an article entitled "Childbirth is Deadlier for Black Families Even When They're Rich." And it also provides some data here that's on the right-hand side of the screen. And more closely linked to the payer is the quote on the bottom left-hand side of the screen from our Blue Cross Association, which released a study with a quote that says, "Women of color are at higher risk of maternal complications, and those disparities persist regardless of whether they are enrolled in commercial health plans or Medicaid coverage." So these quotes are extremely important, and we at Horizon, we know that. And we are taking strides to ensure that we keep this in mind when we're creating our models, which is why, next slide, please. I'm happy to state that with that in mind, this year, January 1st, 2023, Horizon launched as a pilot program the commercial doula benefit for our individual health coverage members. So this is just a step towards ensuring that we identify the folks who need the care the most, whether they are our commercial members, whether they are our Medicaid members or our commercial members. So wanted to highlight this as one of Horizon's strategies thus far. And I'm sure I can go on, but there's a lot more work to be done in this particular space. So I will end here and be available to answer any questions that you may have. And Kate, I hope that I did very well. I stayed within the parameters.
You did great. Thank you. We would
Yes.
even give you another minute if you wanted it.
Okay, that's good to know. But I'll hold for the breakout sessions to go more in depth.
Great. Thank you so much, Dr. Edwards. And at this time, I'm going to turn things over to Greg Woods from the Office of Medicaid. Thank you, Greg.
Thank you, Linda and Kate. And thanks to Dr. Edwards for that great presentation. And it looks like we may be at the end of the slide deck, so if we want to go to the beginning. So I'm going to talk very briefly, and I'm going to do my best also to honor the time request from Kate about our perinatal episode of care pilot program here at New Jersey FamilyCare. So if we want to go to the next slide. And I will just say at the top that I'm going to give sort of a very high level overview in this presentation today. There is a lot more detail about this pilot program that's available on our website, and I can put that link in the chat after I'm done presenting. And I would encourage anyone who's interested to go and take a look. There are a bunch of materials there that go into quite a bit more detail about the design of our pilot. So at a high level, the perinatal episode of care pilot program, this is a legislatively mandated pilot. There was legislation back in 2019 that was enacted. It's a voluntary model for providers. It's focused on NJ FamilyCare, so Medicaid and CHIP members who are enrolled in one of our 5 managed care plans. And the goal of the episode pilot is to improve quality and lower the cost of maternal and infant care in New Jersey, and with a particular emphasis on addressing disparities in quality among perinatal care within our NJ FamilyCare membership. And I will just pause here and note, I think this may distinguish us from some pilots or similar programs that may exist in other states. Our primary focus here has been on improving quality and improving outcomes for mothers and infants within our program. And then I think the cost element for us is doing that in a sustainable way. So this episode of care pilot program, it launched in New Jersey in April of 2022. As I said, there was legislation back in 2019. As you may remember, there was a pandemic in between then and 2022, but we continued to work. We partnered with a stakeholder steering group, and the Quality Institute was instrumental in facilitating that. That included a range of representatives, providers, managed care organizations, various stakeholders. And as I said, we launched in April of last year. So we were in the first performance period. Currently, we have 16 NJ FamilyCare providers participating. These are OB or midwife practices. Some of them are hospital affiliated, some are independent, but collectively they provide care for over 10,000 NJ FamilyCare births a year. So that's approximately a third of our total. So we're really pleased to have such good participation in our first year. So if we want to go to the next slide. So I think Simone's presentation sort of covered some of the basics of what an episode is, so I won't repeat that, but the basic structure here is similar. It involves attributing births and the whole perinatal care period around a birth to a specific provider, and then incentivizing those providers based on quality and cost. And in the context of our specific pilot program, I just want to talk a little bit more about what we mean by both of those elements. So when we talk about quality, there are 5 payment measures that impact providers' incentives under our episode. We intentionally designed these. We worked with our stakeholders to identify measures across the entire spectrum of perinatal care. So including the prenatal period, the delivery itself, the postpartum period, and also the neonatal phase. So care of the infant after the birth. And so you can see on the right here are the 5 measures that for our first performance period are tied to payment. There are 2 prenatal measures related to screening for depression and gestational diabetes. There's a measure related to delivery, which has to do with C-section rates. And then there are measures for both postpartum and for the neonate around visits post-birth within a specific time period. So that's how we look at quality for the purposes of determining incentives within our episode. We then also look at cost. And when we talk about cost of care, it's important to note, and this is a feature of most episodes and payment models in this space, we aren't just looking at the cost of the care provided by the participating provider. We're looking at the whole cost of care of maternity care across the perinatal period. So including labor and delivery costs, including both prenatal and postpartum care. I will note that when we calculate cost, we include a risk adjustment. So we recognize some patients are going to be more complex and have more cost as a result of that. So that's a feature of how we look at cost. So these are the 2 inputs: these performance on these quality metrics, and then performance on spend. And then if we go to the next slide, I'm not going to go into a ton of detail here, but I do just want to call out. There are then 3 payment incentives that providers under our model can qualify for. The first is a shared savings payment. And the basic idea here is if a provider can show that they are hitting a baseline level of quality across all 5 payment metrics, So they're performing where we would want them to perform there. And they're also reducing their spend relative to their historical average. So the spending is going down by a significant amount. Then in that case, we will share some of the dollars that have been saved back with the provider. So that's one, and that's sort of the classic payment incentive that's often built into episode-like programs. We then also have a high performer bonus. So this is structured a little bit differently, whereas the shared savings payment is based on reducing spend based on a provider's historical experience. The high performer bonus is for providers who are high performers, both in the sense that they're performing above and beyond on quality measures. So there we expect providers to hit the minimum threshold for all measures and then be at commendable threshold, so a higher threshold for at least 2 of the 5. And then also have lower spend when you control for risk relative to their peers statewide. So that's a slightly different structure. This is intended to reward high performance, sort of independent of any provider's historical experience. And so there are bonus payments for that. And then our last incentive payment is an SUD participation incentive, substance use disorder participation incentive. And this is an incentive payment that is for providers who have a high percentage of members with an SUD diagnosis. We recognize that can create additional challenges to hitting some of the milestones and goals serving that population within this episode. So in order to incentivize providers who have that patient population, we've created an additional incentive payment to incentivize them to participate. So if we go to the next slide. So I just want to talk about sort of the expectations and the roles for both providers and for our MCOs, for our payers. And I think I sort of peripherally saw in the chat there may have been a question about this. So first, I want to talk though about the role of our participating provider. So obviously, the goal here is to improve quality of care. So a critical part of that is we expect those providers to be providing high quality of care, to be hitting our quality metrics. We also, though, and this is really important, expect providers as part of their participation in the episode to coordinate across the spectrum of care. And so that means taking responsibility for things that are not just provided in their office or as part of the care they provide during labor and delivery, but looking beyond that. So for instance, you may remember one of our quality measures is around a timely infant visit after the birth. Now, that's not something that the OB providers who are participating in our model directly provide. They need, in order to move the needle on that, they need to make sure their patients know about the need to schedule that visit. They need to coordinate with pediatric practices. So in that sense, we're expecting them to go beyond sort of the traditional scope of practice and really be a leader and be a quarterback for the members' care and for the family's care across the entire perinatal period. And similarly, as I said, we are holding providers accountable for the total cost of care associated with the perinatal episode. So that includes both the care they provide, but also care that members receive elsewhere. So if a member goes to an emergency room for a pregnancy-related complication, that would count. If a member seeks services from another provider, that would count. And so it really is looking to expand the scope of the provider's responsibility and really empower and support providers in being a quarterback for all of their patients' needs across the perinatal period of care. I also want to call out that we have expectations that we expect providers participating in our model to be addressing disparities in perinatal care, and particularly disparities around race and ethnicity that, as Dr. Edwards pointed out, are very, very present, I think, across payers and very persistent. And as part of that, one of our requirements for providers in our model is that they develop a health equity action plan. And that's a plan to address one or more disparities within their patient panel. It should be data driven. So it should be based on what they're seeing within their performance on the quality measures that we look at across different groups within their practice. And it's a requirement that they develop a very specific and detailed plan to address those disparities. And that's something we're sort of piloting with our providers, testing different approaches, and I would expect will continue to evolve over the course of the pilot. I then want to just talk for a moment about the role of our managed care organizations. And I think there was a question about sort of how does this model relate to the the model that Dr. Edwards described for Horizon. So I will say all 5 of our NJ FamilyCare MCOs, which are listed here, are required to participate in this model. And that's a contract requirement that we've put into our managed care contract that we sign with our MCOs. Part of what we heard from providers is that it's important for them to have alignment if they're serving a Medicaid population who are enrolled in several different MCOs, that the incentives be aligned for that population. So to be responsive to that, we have standardized this model for the Medicaid population, and all 5 of our MCOs will be following the same model. And the performance will be calculated centrally across all of the providers' patients across all 5 MCOs, and then payments will flow out through the managed care organizations. And we have been partnering closely with the MCOs as well as with providers as we move forward with the model. So moving on, I just want to talk quickly about sort of how we think about this. As I say, this is a pilot. We are in our first performance period, which is from April of 2022 to June of 2023. We expect there to be 2 more performance periods each year long, from July to June, so from 2023 to 2024, and 2024 to 2025. We expect, this is a pilot, we're learning as we go. So I would expect that in subsequent years, in years 2 and 3, we will tweak some of the design choices and introduce new elements. We may review performance metrics. We may review some of the financial incentives. We expect that to be a very collaborative process with our stakeholders. And our hope is that as we go through that process, we will be building a program that can be a permanent part of the Medicaid program moving forward. But as I said, this is a pilot. I was involved in a previous role when I worked for the federal government in developing this kind of alternative payment model. One thing I can say is that you never get it exactly right on the first crack, and you need to test it in the real world and then adjust. And I expect that's what will happen here. And then I want to note that an important part of our work here will be to evaluate the effectiveness of this model. And there's a legislative mandate for us to do that. It's something that we will be doing informally over the course of the 3 years, and then doing more formally after the end of the pilot to really see, we designed this model. We had certain goals around quality, around cost, around disparities. What are we seeing in the data? Are we achieving those goals? And that's a critical part of this evolution. So as I said, there's a formal evaluation that we expect will happen after the conclusion of our 3-year pilot period. But every day as we get more data, we are looking and assessing about how we're doing and what we're seeing. And we're still in the early stages, but that very much informs our thinking about the pilot going forward. And then lastly, I'm just going to very quickly call out, I have focused on my presentation today on this perinatal episode of care pilot. I just want to flag, though, this is not the only thing happening at Medicaid and FamilyCare related to maternal and infant health. As part of the Nurture NJ initiative that's being led out of the First Lady's office, we have a number of different exciting initiatives going forward, all of which are focused on better outcomes, better quality of care for mothers and children in our program. And just to name check a few of them, I'm not going to go into a lot of detail. We have our Cover All Kids initiative, which is focused on making sure that all children have insurance in the state. Our 12 months of postpartum coverage, which means that mothers in NJ FamilyCare will maintain coverage automatically for 12 months after the end of the pregnancy, regardless of whether they have a change in circumstances. Our integrated care for kids model, which we partner with the Quality Institute and other stakeholders on, which is focused on, is a pilot focused on addressing children who have both social and clinical complexity and making sure they get the care management they need. Just talked about the episode of care. Our doula work, which is focused on the doula benefit that was rolled out within Medicaid a couple of years ago. We have recently increased our reimbursement for maternity care across for midwives and OBs and for doulas. And then we also call it QuipNJ, which is a program we run in partnership with the New Jersey Department of Health using Medicaid dollars and focused on the hospital side of the world. So, and this is not an exhaustive list, but I just want to sort of make clear that this episode is part of a broader suite of initiatives that we're undertaking within Medicaid. So I will stop there. I hope I stayed within the time, and happy to take any questions during the breakout session.
Great. Thank you so much, Greg. Thank you for all the work that that you're doing and for that really excellent overview. And there were many questions coming in, and as Greg just mentioned, we will have time for all of them in the breakout room. So thank you for your patience. At this time, I'm going to turn things over to Pam too.
Thank you so much, Linda, and thank you to the other presenters. As a mom, as a social worker, I'm just honored to be part of this panel. I'm going to tell you a little bit about the model HealthySteps, and then I am going to talk about how we think about payment in terms of sustaining and growing HealthySteps in different states and what we're trying to do here in New Jersey. So HealthySteps is an evidence-based model that exists at pediatric primary care practices. So HealthySteps can exist anywhere that well child visits take place. And essentially what the model does is operationalizes team-based care for very young children ages 0 through 3 and their caregivers. And we really think about both the child and the caregivers as the patient in the HealthySteps model. So these are HealthySteps is a type of dyadic service or 2-generation service delivered to families in the pediatric primary care setting. And we do this by adding a team member to the team called a HealthySteps specialist. That's someone with a child development background, often a behavioral health provider. And they are right there in the practice with the primary care providers, going in and out of rooms just like the doctors and other practitioners are, and they're adding that interdisciplinary approach to delivering pediatric primary care. And on the next slide, you'll see the different core components of the model. So HealthySteps, if you're going to be a HealthySteps site, you have to deliver on 8 core components of the model. And it's a population health risk stratified model. So Tier 1 services are delivered to all children ages 0 through 3 in the practice and their caregivers. And really what Tier 1 services do are operationalize bright futures, and we add a few additional components to screening on top of bright futures. So screening for child development, social emotional health, and behavioral health, and also screening for family needs, ensuring that all mothers are given postpartum depression screens, and also screens for social drivers of health. Tier 2 services are delivered by the HealthySteps specialist to families who maybe need some short-term support. So we have child development and behavior consults as a core component of Tier 2. Those are really 1 to 3 visits with the HealthySteps specialist to address a discrete issue that might be going on with a family, maybe something that the primary care provider doesn't necessarily have time in their day to go into depth with a family. They can call in the specialist and have a meeting right there on the same day as their well child visit. Also, care coordination systems navigation is part of Tier 2. So families who need help connecting potentially to early intervention, maybe if a mother screams at risk on the postpartum depression screen, the HealthySteps specialist can help mom get connected to needed outpatient services. Also, the delivery of positive parenting guidance and information and early learning resources are part of Tier 2. So that, is expected to be part of traditional pediatric primary care, but really HealthySteps enhances the delivery of that content through different means. And we are part of, HealthySteps is part of 0 to 3, the early childhood nonprofit, and we have a host of resources that are accessible to our network to do this kind of delivery of education. Tier 3 services are for families most at risk and add an additional core component to the model. So that is the delivery of ongoing preventive team-based well child visits. So essentially the HealthySteps specialist co-manages every single well child visit alongside the primary care provider for that entire first 3 years of life. And I just want to note that some sites do continue to do HealthySteps through age 5. So on the next slide, just briefly touching on the evidence-based. So I mentioned it's an evidence-based model. HealthySteps went through a randomized control trial in the mid-2000s, and that evaluation, along with subsequent site-level research, has shown that HealthySteps increases connections to resources, increases breastfeeding rates, and improves early nutrition. improves child's health and development, improves parenting knowledge and practices, increases parent and physician satisfaction, reduces maternal depression, improves early literacy and school readiness, and increases child safety. HealthySteps also advances health equity, which we'll talk about on the next slide. By nearly every measure, children living in families with low incomes and children of color face the biggest obstacles, such as low birth weight, unstable housing, and limited access to early learning experiences. Just at a time when the brain is developing most rapidly, HealthySteps brings focus to the important array of skills needed for families to foster healthy child development and lifelong well-being, leading to improved outcomes, especially in areas where there have been persistent inequities for families of color or those with low incomes. HealthySteps ensures more frequent screenings, emphasizes the importance of early relational health, and supporting social emotional development, and supports mothers with breastfeeding and their own mental health. There's been recent research that shows that children in a HealthySteps practice were diagnosed with autism and 2 years earlier on average than the national average. So the evidence is clear. On the next slide, we show the Heckman curve. The evidence is clear that investing early in a child's life improves their health and well-being outcomes across their lifespan with long-term benefits to both the individual and society. But as most of you know, our healthcare system focuses heavily on opportunities for cost savings in the short term. The next slide shows how HealthySteps also can have a return on investment for state agencies even within 1 year. So in partnership with Manat Health, the HealthySteps National Office developed a return on investment model that showed a 163% average annual ROI across sites. That means for every dollar invested in HealthySteps, an estimated $2.63 is being realized by the state Medicaid agency. And if New Jersey Medicaid were to invest in HealthySteps, there is a potential to realize $1.63 for every dollar invested. We actually did this analysis here in New Jersey with our initial HealthySteps pilot sites, which just in the first year showed an 83% ROI. And we're going to continue to update that analysis as our sites continue to implement the model and additional sites are added to the network. We're increasingly seeing investment from state Medicaid agencies as they create sustainable reimbursement pathways for models like HealthySteps. Next slide, we're trying to articulate kind of what has traditionally been paid for in behavioral when we think about the delivery of behavioral health services. On the right, we really think about behavioral health payment in terms of covering treatment. So when there's a problem identified in the behavioral health of children or adults, there's generally a diagnosis, DSM diagnosis, and that is required to bill a behavioral health code. What we don't see generally across the country are payers, either Medicaid or other insurers, paying for preventing behavioral health, right? So we think about on the physical health side, we pay for prevention, right? Preventive screenings, delivery of education for people to understand risk factors for developing disease later in life. We just don't see that on the behavioral health side, but that paradigm is shifting, which is really, really exciting in the past few years. And we've seen states make huge investments. And when I say huge, sort of monumental, right? Innovative, not necessarily huge in terms of dollar amounts, because especially the children ages 0 through 3 are relatively low cost. And so payers are not always, thinking about innovation in terms of a population that's relatively low cost because they're looking to reduce costs for high cost utilizers, right? So then on the next slide, I'm going to talk about what we're trying to do here in New Jersey in terms of this kind of payment innovation, and then give a couple of examples from other states and examples we're trying to encourage New Jersey Medicaid to adopt. So we've, on the left of this slide, we've seen great investment from our philanthropic partners. So the Burke Foundation, the Turrell Fund, and at the time, the Nicholson Foundation partnered with us at the national office and Hackensack Meridian Health to start up the first 4 pilot sites of HealthySteps, which happened in 2020. And those sites went live at the beginning of 2021. The funding is supporting the pilot sites, but also supporting our national office's work and our sustainability partners, which the New Jersey Healthcare Quality Institute is one of, alongside ACNJ, Seton Hall Law School, and now the NJAAP, to do this sustainability advocacy. So really working with stakeholders, with state agencies to open up reimbursement pathways and funding streams that can support the scaling of HealthySteps across New Jersey. And when we think about sustainability, it's not necessarily program funding, right? With this model being integrated into the healthcare space, we're thinking about healthcare payments through either fee-for-service or alternative payment models that can support HealthySteps. So any pediatric practice in the state could do HealthySteps if they wanted to. So we're sort of in the middle here. We're doing the hard work to try to sort of check the box on sustainability, which obviously it's not that easy or seamless. And we even know when the reimbursement pathways are open, we need sites to support sites' ability to leverage those. And then our goal is to scale, right? And that is not only the goal of our national office, which we're doing across the country. So we're currently in 24 states and Washington, DC. But also our philanthropic partners and communities' interest in these kinds of services, putting services where families are, right? Thinking about true primary prevention, and knowing that every parent takes their child in for those child visits in the first 3 years of life. It's a really amazing opportunity to partner with families. So the next slide shows what we call the Maryland model. So it's a newly developed model in the state of Maryland. And we're really encouraging this model in New Jersey for a variety of reasons. But one is that in Maryland, behavioral health is also carved out of the state's managed care program for the most part, which is true in New Jersey. And it's when we think about integrated care from a practice standpoint, and then we think about payment and how those two align. When we think about fee-for-service type solutions, payment solutions, which I'll show you on the next slide is California's example, which is very fee-for-service based, it's difficult when the payment is not integrated, right? So when we think about billing a behavioral health code in a primary care setting, it would go through Medicaid fee-for-service, yet the physical health payment is coming through managed care. Right. And so thinking about when a family comes in for a well child visit, they're seeing a specialist and they're seeing the primary care provider. It can be administratively very complicated for our practice to bill for both of those services, even if the billing codes were open. So what this does is provide an enhanced payment on top of every single well child visit and sick visit for any child 0 through 3 in a HealthySteps practice. There's a new provider enrollment category created that the HealthySteps site enrolls in the Maryland system, and we provide a letter that says that that site is on track or meeting fidelity. So we monitor fidelity at the HealthySteps National Office and put a lot of effort and resources into that. So the state is leveraging that work to ensure that the 8 core components are delivered. And so it's a relatively low cost to operate HealthySteps. We say that it's an average of $50 to $80 per child annually to deliver the HealthySteps model. So really a low cost and effective way to address the, I think the many, goals of the MAP to Action project, right? The outcomes are in those same domains, but a relatively low cost way to operationalize that, and a non-stigmatized way to do that and deliver services. So I can talk a little bit more about the California approach, which is based more in fee-for-service in the breakout rooms if anyone's interested, but that enhanced payment type of approach is really what we're trying to push here in New Jersey.
Pam, thanks so much. And thanks, Dr. Edwards and Greg as well. I know we've had a lot of activity in the chat room, and there's still additional information to discuss and share. So we are going to move to our breakout rooms right now. You'll see at the bottom of your screen the option to move to a breakout room, and we'll have 2 rooms this morning. The first room is labeled Theme 1 Payment Reform. And Linda Schwimmer will be facilitating that room along with Greg Woods and Dr. Simone Edwards. And so that conversation can continue there. Additionally, we'll be talking about integrated care services, including HealthySteps, but just looking at integrated care across the perinatal delivery of care systems. So I'd invite you to join us in room 2, which is labeled Theme 2 Integrated Care Services. I'll be facilitating that room, and Pam will be joining me there as well to talk about a variety of models of integrated care. So we'll see you all in those rooms in a moment. Hey everyone, welcome back to the main session. We're going to get report outs from both groups because I know people wanted to be in both sides but weren't able to. I'm also going to share an opportunity for you all to be participating in a nonverbal way. We do have a Jamboard that's up on this topic. And the link to that Jamboard is in the chat now. So if, as you're listening to our report out from both of the breakout rooms, we'll have opportunity for a little bit of dialogue, but if you just want to jot down thoughts or questions or pieces of information you want to share, you're welcome to connect to this Jamboard. You can grab a little sticky note over here on the left and just write your note here, and then it'll be popped up here, and it's a good way for us to save what everyone's thinking if you don't have a chance to chat. So I'll take that down. I'd love to call on Theme 1. I'm not sure who's doing your report out, but if you are, please take yourself off mute and share what went on in that room.
I think it's me. I don't think anybody volunteered, so I'll take this one. So in our Theme 1, we had started out with some questions about what were in the chat box during the original presenters. So we started answering some of those. The first one was, what is the difference between the Horizon Episodes of Care program versus the Medicaid program? And Dr. Edwards shared that it is currently commercial episodes of care, but when it was started in 2014, it hadn't included the Medicaid population, but now that the state has its own program, it no longer does. Another question about stakeholder feedback about standardization across measures across the MCOs. And for that one, for the state episode of care program, it's a voluntary program for providers. So the group of providers that are participating felt that it was important to have one set of measures across the different MCOs, and that it would be overly burdensome for them to manage 5 different programs and measures. Another question about how to evaluate success in the episodes of care programs. For Medicaid, it's more about looking at the impact on providers before and after the model was started. Good point that the evaluation, given the time that we're in right now and when the program started, it's been made a bit more difficult because of COVID, but that the performance metrics would likely stay pretty consistent from year 1 to year 2, but they would be looked at and potentially changed if there was a need to. And then on the Horizon side, providers were reporting through their programs that their members were more educated and more in tune with their health based off of the information they were receiving due to the episode of care program. Next, we had a suggestion that folks could work together, potentially with folks from Rutgers to co-design research, primarily around the use of data. It was suggested that there's really not a lot of data about race and ethnicity in particular, which makes the work a bit more difficult. And then on the Medicaid side, not having a lot of data, but sharing best practices has been a focus. And a question about training for providers. So is there training around episode of care for providers? Suggested that would be something good to look into on behalf of each of the MCOs if there were individual trainings being provided. But because Horizon was there and represented, they shared the episode of care team works with providers in the commercial program. And so when folks enter the program, they're given a rundown and participate in monthly meetings. Educational materials are available, and there's an ongoing education that's provided. I think everyone suggested that that would be something helpful to look into with all of the MCOs and understanding if there's ongoing education that could be available. Next, we talked about community health workers being used for outreach to address disparities. Dr. Edwards shared that the Neighbors in Health program in Horizon utilizes community health workers to do just that. And they are looking more specifically at which zip codes need more participating providers, and the community health workers come into play there. That's something they're looking to do more of in the future. In the Medicaid program, most of the providers that participate have hospital affiliations, and they are looking to potentially increase the participation of smaller providers, but that their volume may be a factor in whether or not they want to participate in this voluntary program. And then lastly, a question about what would short and long-term success look like for payment reform, and shared a couple of different strategies here that we should broaden interdisciplinary approaches. We also need to have a better understanding of effective strategies for different populations. So which interventions are working, which are effective for payment models, what do they need to include? Both Medicaid and Horizon shared that these are ongoing and iterative programs that are constantly looked at to make improvements, and looking at outcomes based on race and ethnicity and improving infrastructure around data were all important elements of success, both short and long term, for payment reform. And that was pretty much it. Thanks.
Thanks so much, Tyla. I'll ask Brianna to come off mute and give a report out for group 2.
Hi, everyone. So group 2, we started our discussion with going over California's dyadic benefit, which you can all view in the slides that we'll share, since we didn't get a chance to talk about that in the larger group. But really, we then turned towards talking about return on investment, which can be seen within the HealthySteps model. And Pam actually mentioned that the cost savings from that is really more so on the physical health side. So we definitely see a return on investment on integrated health services. Additionally, the advanced payment model is really a flexible payment model, and it allows for innovation. So it can be used in other models as well. We spoke about some other programs aside from HealthySteps, including Centering, Reach Out, and Read, which are providing patients as well as their families with high quality of care. We all turned our discussion similarly to theme 1 to talk about community health workers and doulas and their role in all of this, because they are extremely important when it comes to being on the ground and communicating with families. But it's important to make sure that they are trained appropriately to communicate with families. It's not likely that a patient will necessarily say in a physician's office what they're dealing with. So having these community health workers really, in a sense, closes that gap and allows patients and families to feel more comfortable. And then we turn to talk about some of the challenges that people face, which we all know time and resources is a main one. It's difficult for providers who do want to educate their patients when they come in for a visit, but between time restraints as well as heavy workloads, it can make it difficult on the providers to do such that. But there really is great benefit with using models like HealthySteps. The benefit to the patient, there can be behavioral changes, as well as for families, the resources that they're connected with. But then the physician at the end of the day really does get that financial benefit. So it's important that they feel supported to get the work done to really benefit everyone. And then a really great question that was brought up was, well, how can people who are not in the payment world still support this work? How can we support reform and alternative payment models? And one thing that Pam said was really understanding the policies that are out now that impact families, but also tracking bills that are currently on the table, that are pending on the legislative side, having meetings with your local legislators or site visits to really get that understanding. That can all play a role. And then in regards to philanthropic support, there was some interest in having safety net providers in the state of New Jersey. So how could this funding from the philanthropic side be used to support models like HealthySteps and other models? One example of that is using the funding to support the IT department so that their structure and system can be set up to support one of these models. Additionally, although this might be a little trickier, supporting the staff to, paying the staff to participate in activities such as advocacy as well as lobbying, but also sending staff to be part of conversations like the ones that we're having today, so that everyone, physicians, specialists, people of all different areas can become on the same page about what's taking place.
Thanks so much, Brianna, and thanks to Tyler. If we have forgotten anything that was summarized during your session and you want to take yourself off mute to add, I know we put a tall order on both of these individuals to give us a report back. I'd also like to invite, in the last few minutes that we have here together, anything that's sparked interest or sparked a thought in your head. We know that you're hearing new information from the other breakout room, so I'd invite you, if you'd like to share, to pop your hand up and take yourself off mute. Or if you're feeling like you're just absorbing all of this information, that's fine as well. But I'll give it a minute for folks to jump in with conversation or questions or thoughts. Be comfortable in the silence is what they say. She awkwardly takes herself off mute. Well, I really appreciate everyone's time here today, and to our speakers. I'm going to turn it over to Linda for final thoughts and wrap up.
Thanks, Kate. And I also echo your appreciation to all three of our speakers this morning. I want to remind everybody that you still have an opportunity to engage with our speakers from today and further engage on the topic of payment, as well as the first three topics, which were on data, community supports, and I knew I would do this. I feel like that cabinet member who forgot the fourth.
Workforce.
The energy department, yes, and workforce. Thank you. On Friday, we are going to be holding our Map to Action convening. You'll be hearing from two phenomenal leaders in maternal-infant health, Assistant Commissioner Lisa Asari and our board member Linda Sloan Locke, who's been a leader in reproductive justice and maternal health for decades. We'll have an opportunity to hear from 12 different organizations that are providing innovative programs across New Jersey at lunchtime, and we'll have two breakout sessions where we will be mapping your work on the map. And that's really where all of these worksheets that you've been providing us with come into play. And we'll be having breakout sessions and discussions digging deeper into these four topics that we've discussed today. Really, the purpose of all of this is not only to educate and inform you, but to enable you to share the work that you're doing, you to connect with others who are able to further your work, and to really advance all of the goals in the map into the future. So thank you again for participating. We will again share the link to that worksheet I keep promoting, and the link to register for Friday's conference. I think today or tomorrow are the very last day to do it. So please do that quickly if you're thinking about it. And have a wonderful rest of your Monday. Thanks so much.